Welcome everyone to today's Global Grand Rounds. My name is Maria Malana, and I will be your host for today. Today's presentation is not CME approved, as we are still in the process of figuring out our CME certification. And so before we start, I'd like to go over a few things. This presentation will be recorded and uploaded to our YouTube channel. If you wish to watch our videos on YouTube, there's an option of playback speed to adjust the speed of the presentation. And on Zoom, you may turn on the feature called closed caption during the presentation to allow for subtitles. And one last thing, unfortunately, Dr. Pekia, our medical director, will not be present for today's presentation. And so I will go ahead and introduce our speaker for today. We have today Dr. Katsaros. He is a graduate of Midwestern University Chicago College of Osteopathic Medicine. He completed a traditional rotating internship at San Bernardino County Medical Center. He then trained at Loma Linda University Medical Center for his internal medicine residency and rheumatology fellowship. During his career, he has been the director of the Rheumatology Fellowship Program and Associate Chief for Clinical Practice for the Division of Rheumatology at Loma Linda. He currently is a professor and chair of the Internal Medicine Department for College of Osteopathic Medicine of the Pacific, COMP, and COMP Northwest at Western University of Health Sciences. Dr. Katsaros continues to practice and supervise fellows, residents, and students in clinic. Thank you so much for coming today, Doctor, and I will hand over to you to get started.
Well, thank you so much for inviting me to speak. And this is a wonderful organization, and I was, of course, quite active a few years ago with the organization, and it's wonderful to be back. So yeah, what I'm going to do is share the screen, and hopefully everybody could see that, and hopefully everybody can hear me as well. Yeah. Okay.
Good.
Okay, great. So I'm going to pose a question. I'm going to put forward a case, and then for your consideration, is this Sjögren's? And we're going to talk about Sjögren's, but we're also going to talk about some of the things as well. So let me just go forward to the case. Good. So this is a patient of mine that's 63-year-old with a 63-year-old gentleman that has dry eyes and dry mouth, and he has this foreign body sensation of the eyes, swollen submandibular glands, parotid glands for the past 5 months. And he describes swollen eyes. He developed swollen eyes, and he had a severe sinusitis prior to these 5 months where he had these submandibular. So the patient didn't have any shortness of breath, no coughing, joint pain or joint swelling, no swelling of the legs, no fluid retention. He had no Raynaud's type symptoms either, and no rashes. No known drug allergies. He did have, the only past medical history was a history of seasonal allergies. He wasn't on any medications. At the time when I saw him, he was a retired owner of a furniture retail store. He had no history of tobacco use, drink about 1 glass of wine a week, and no drug use. The vitals are there. He did have enlarged parotid glands bilaterally, dry conjunctiva. The nose was not deformed. It was non-tender. There was no erythema either. The throat was dry. The mucous membranes in the mouth were dry. No ulcers, no erythema, no lymphadenopathy. The thyroid was symmetric, normal size. Submandibular glands were enlarged, and they were non-tender. Everything else, the respiratory, cardiovascular, GI, it was all normal. There was no edema, no clubbing, again, no Raynaud's. There was no, on exam, there was no synovitis in the upper or lower extremities. So no joint swelling. There was no rashes, no lesions in the skin. So given this, does anybody have any thoughts? Now, I think I've already tipped my hat, but if you have any other thoughts, let me know. So
well, I think that yeah, I could I could take a really great guess and call it Sjögren syndrome, but I would what I would say in there is from my own personal experience, because I've seen a few of these patients in my time, not a lot of them, but as an OMM guy, I used to get a lot of referrals for people with all kinds of pain, and a patient like this would have triggered something in me to explore, because he might have been referred to me for neck pain or back pain or something like that. But when you look at the history, and I can imagine examining this person, it's not that kind of musculoskeletal pain. It's clearly some kind of an inflammatory joint pain of some kind. It doesn't mean that I couldn't help him with some OMM, but it means that there's a bigger diagnosis to be made here. That's what would strike me, and that's what happened with some of these patients. And the few that I've had definitely had the eye syndrome, symptoms with their eyes and the mucous membranes. And that's one of the things that actually triggered me about this problem in those patients. So.
Yeah. Yeah, very good. Yeah, this patient, I'm going to move back a little bit if I can. And I kind of failed to put an important thing in there with this. There was some periorbital, and I can't believe I don't have this in there, and I apologize for that. There was some periorbital swelling as well. So the eyes were swollen, not huge, but they were quite puffy around the area. And I think that should have been noted, and I apologize for that, because I just realized when you said about unusual, I says, wait, I don't think I mentioned that. So Sjögren's was certainly a consideration, and a strong consideration when I saw this patient. And he was certainly beforehand seen by the primary care physician, and that was the diagnosis at that time. That was the working diagnosis. But for me, what made it unusual was that periorbital edema and the degree or the involvement of the glands. That, yes, I do see parotid gland involvement, but the amount of swelling that he had submandibular was a little bit unusual. Sometimes you do see that, but you don't see that often. The other thing to note, the amount of dryness that was there, it was dry, but I've seen a lot worse. And usually I see a lot worse with a lot more gland involvement, like this gentleman. He was quite involved with swelling. You don't always see that swelling in Sjögren syndrome. So there were some things that may be a little bit uncomfortable with the diagnosis, but this was the working diagnosis going forward. So I'm going to talk about Sjögren's first, and then we'll see what happens. Okay, so chronic inflammatory disorder characterized by lymphocytic infiltrates of the lacrimal and salivary glands results in the dryness of the mouth and dryness of the eyes. So the initial signs and symptoms of Sjögren's are keratoconjunctivitis sicca, where they have the dry eyes, seen in about 50% of patients initially, as well as the dry mouth, the xerostomia. Everybody usually gets this within months of actually having the initial symptoms. And usually when I see them, because it's not easy to get in to see a rheumatologist, we usually see the full manifestations of both dry eyes and dry mouth, and universally in patients with Sjögren's typically. Yes, arthralgias and arthritis, they will have that. They'll also have myalgia, although I don't have that listed, to a lot of achiness in their body, and often will seek out physicians that do osteopathic manipulative treatment. Raynaud's fever, they'll have dryness throughout their body, including the skin, vaginal dryness, for instance, as well. That's not seen in everybody, but can. Fever's not seen in everybody. Raynaud's is not seen in everybody either. And you got to keep in mind that the Raynaud's can be primary, just Raynaud's itself, or you can have it as a overlap syndrome with other conditions, such as rheumatoid arthritis and lupus. So just talk a little bit more about the oral manifestations. Yeah, they get such dryness of the mouth that they really have really poor dentition. They get a lot of cavities. We're always telling patients to see their dentist regularly every 6 months. And it's so dry that you no longer have great defenses it affects the flora in the mouth. So you wind up with oral candidiasis. And actually, the picture to the right is oral candidiasis. We don't normally think of that, right, with the redness of the mouth, usually with white plaques. We can see that, but we also can see it to the point where it's so dry it's just red. And you treat this like you do any other oral candidiasis patient, and they do have improvement. These patients will have burning the mouth when it looks like this. And that sometimes that'll be the complaint that comes to us, is burning of the mouth, and it's actually underlying Sjögren's. These patients have such dryness they can't eat really without any water. And there's a great Sjögren's researcher that came to lecture once, and he says, I call it the cracker test. And if you're able to eat you should not be able to eat a cracker without drinking water. So that's what I ask patients. And almost universally, a patient with Sjögren's will say, I can't eat without drinking any water. And they always have water present with them all the time because they're needing water all the time. The differential diagnosis, when you're thinking about it, for dry eyes and dry mouth, you kind of have to think of it in those type of categories. And certainly drugs are a big factor: antidepressants, neuroleptics, anticholinergics. And there was a study that was interesting that if you're on 6 or more drugs, you're likely to have dry mouth. And I don't remember to what degree the likelihood was, but it was significant that you would have dry mouth if you're taking that many medications. So keep that in mind. Drugs are also associated with dry eyes, but with dry mouth, you could have diabetes. Diabetes can cause dry mouth. Anxiety, HIV, hepatitis C. HIV can also cause the dry eyes. Radiation to the neck, of course, can give you dry mouth as well. Dry eyes is a classic vitamin A deficiency, and it's really what xerostomia, when we think about xerostomia, we think about vitamin A deficiency. Age, as you get older, and any trigeminal nerve, facial nerve damage can give you that as well. So the other things to think about, if you do happen to have parotid enlargement in your patient with Sjögren's, and this patient that you see before does have Sjögren's or was diagnosed with Sjögren's. This is taken from the American College Rheumatology slide deck. And these patients, things to think about in these patients when it's bilateral are viral infections, mumps, HIV, Coxsackie, certainly Sjögren's, but also diabetes, bulimia, and cirrhosis of the liver. When it's unilateral, there are not that many things to cause this problem. Think salivary stones, but usually they'll have a lot of pain associated with them. So with that, some redness, perhaps tuberculosis, lymphoma, but you should not be thinking that, gee, it only can be unilateral if it is lymphoma. No, it can be bilateral. It certainly is. It progresses. And then other manifestations of Sjögren's, you have involvement of the exocrine glands of the upper respiratory tract that leads to dryness of the nasal passages and the bronchi. That can eventually involve the tracheobronchial mucous membranes and lead to a dryness there as well. In the lungs, you can get an interstitial lung disease, or you can get just inflammation of the lining of the lungs, and it'll result in pleuritic type chest pain, and you'll have because of pleurisy. A lot of patients with Sjögren's complain about difficulty swallowing, and that's mostly because of the decreased salivary production. When you're looking at these patients, by the way, you'll notice that they have just a decreased or no salivary pool. When you have them lift up their tongue, they're able to do so. You'll see in normal people, quite a bit of a salivary pool. When it's severely diminished, that's a great sign that you may have Sjögren's. And those patients often will complain that they're having difficulty swallowing. That's why they need to have water when eating a cracker. Sjögren's does have a small degree of inflammation, but often sedimentation rate and C-reactive proteins aren't significantly elevated, but they will, as a result, have subclinical coronary artery disease to a larger degree than if they did not have Sjögren's. Pancreatic insufficiency can be seen, renal disease can be seen, and they could have interstitial nephritis, and that could result in a renal tubular acidosis. We talked about the myalgia, the arthralgia, and the arthritis, which is usually a non-erosive type of arthritis. They can also get associated with rheumatoid arthritis, which is erosive. Cutaneous vasculitis can be seen. They can also have an annular rash where it's red, it's annular, or it could be a serpentine type pattern. It's in waves, it's very thin strips on the arms, for instance, with overlying scaling, and it could look like subcutaneous lupus erythematosus, SCLE there. But even though it looks like it on exam, the biopsies are distinctly different. So it's not actually subcutaneous lupus, but it does look like it. And these patients generally have an SSA and SSB antibody associated with it. It is 40-fold, they have a 40-fold higher risk for developing lymphoma. And that's something that we inform our patients about so that they can make sure that they're aware of a higher risk. It's still relatively uncommon, even though it's 40-fold higher. The lymphomas arise typically in the salivary glands. You will find cervical lymph nodes involved. The lymphomas are the type that you typically see. Again, it's pretty rare, though, overall. Interstitial cystitis can be seen, and peripheral neuropathy is fairly common, but in Sjögren's syndrome, you get a small nerve damage, which leads to the peripheral neuropathy. So the laboratories, rheumatoid factor is heavily associated with Sjögren's. 75% of the patients can have a positive rheumatoid factor. Anti-nuclear antibodies can be up to 80%, and the SSA and SSB, the Rho-Law antibodies, seen in about 70 to 75%. These are ribonuclear proteins and antibodies against those. Now, the thing about the SSA and SSB is that they're, fairly good sensitive, but you look at it, it's like 30% of the time 30% of the patients may not even have it being positive. So you really have to rely on, clinical impression. They're also not specific. SSA and SSB are not specific at all. So you see that quite a bit in lupus patients. So, you have to be aware of that. And you can see it in rheumatoid arthritis as well. So how do you diagnose Sjögren's? Certainly the signs, the symptoms, the positive SSA and SSB antibodies do help. You look at that salivary pool to see if they've got a lot of saliva there. And if there is any doubt, you biopsy and you do a minor salivary lip biopsy. So just in the inner lip, you get a little bit of that tissue, you send it to ENT, usually does them, and you confirm the presence, of lymphocytic infiltrates. So that's what you're looking for, is lymphocytic infiltrates involving the glands. But in order to have a good biopsy, you need about 4 salivary gland lobules. It should be biopsied through normal mucosa as well. So back to our patient, we're going to look at the labs. Now, the sedimentation rate was about 29. If it's a hugely inflammatory condition, you will find much more elevation in the sedimentation rates. You see large elevations in vasculitis for sure. You'll see a larger elevation in the sedimentation rate with rheumatoid arthritis. But this is not, sedimentation rate of 29 would not be unusual for somebody with Sjögren's. The SSA and SSB being negative does make you wonder about it. Again, they can have negative, but majority do have a positive SSA and SSB. And even perhaps a higher amount, or at least an equal amount, has a positive rheumatoid factor, and this patient's rheumatoid factor was negative. So it kind of makes me wonder. It made me wonder because you have the swollen submandibular glands, the swollen parotids, the periorbital swelling, which you don't typically see a lot in Sjögren's. SSA that was negative, the rheumatoid factor negative. So, what should be done with a patient in this case? What do you do? Any thoughts about where you would go next? One thing when you have this situation is you want to see what's going on. Keep in mind there's a huge increased risk of them having lymphoma as well, if it is Sjögren's. So it makes you wonder about that. So this patient was sent for a biopsy, and it was a biopsy of the submandibular glands. And what's needed in that situation is a core needle biopsy. and it was done to the right submandibular gland. And what we found is more than 100 IgG4 plasma cells per high field, and with dense lymphoplasmacytic infiltrates. And there was little areas of fibrosis, but it did not have the storiform appearance, and I'll get to that later on. But that's a woven pattern of collagen with lymphocytes involved. And there was, importantly, no evidence of lymphoma, but you had a lot of IgG4 plasma cells, this lymphoplasmacytic infiltrates, and some fibrosis, and this was consistent with IgG4-related disease. So that does, change quite a bit about what the situation. So I'm going to talk about IgG4-related disease. And by the way, if there's any questions, please feel free to stop me. We're a relatively small group, so I'd be more than happy to take any questions along the way. So the incidence is fairly small, like around 1 per 100,000, but that's not that small for a rheumatology practice. There's not that many rheumatologists per 100,000, at least in the U.S. Typically. So you'll definitely, for rheumatologists at least, see it, and I think a lot of primary care doctors could see it as well. I'm interested in this case. I was interested in this case because my feeling over this is IgG4 is relatively new. It wasn't really recognized until I think it was 2003, if I'm not mistaken, as an entity. And a lot of patients prior to that, or even around that time, a lot of people were not considering this. We would have cases of Sjögren's where you do biopsy and you'd see just a lot of fibrosis. And you thought, well, they just have a really severe case of Sjögren's, that it just basically wound up causing so much inflammation, it obliterated the glands and it wound up being fibrotic. And it just makes you wonder over the years. I had a patient that was considered to be, that I inherited, that was diagnosed with a ANCA vasculitis. We'll get in, that's one of the differentials for IgG4. And it was involving her eyes. And she had periorbital swelling. And she also had some dry eyes and dry mouth, but not so severe. And that's something consistent with IgG4. So it's interesting. She was treated for this, and she did well as a vasculitis patient. But you wonder as to whether it wasn't IgG4 related disease. As a biopsy was actually never performed. It was just based on serology and her presentation. So I think that I think for the most part, I think it's underdiagnosed. A lot of people don't consider this entity. So typically it occurs in men age 50 and older, but really any age and any gender can be affected. Fibrotic inflammatory disease that can affect multiple organs. It's a mimicker. It's a mimicker of all sorts of diseases, which we'll talk about later on. So what are the clinical features? You certainly can have salivary gland involvement, lymphadenopathy. Patients are often afebrile. They feel generally well. They don't have fevers typically. And the thing about it, though, is that multiple organs can be involved. So the symptoms are pretty much specific to those organs that are involved. It can affect the pancreas. It can give you an autoimmune pancreatitis. And that autoimmune pancreatitis, AIP here, was one of those things that, again, was often misdiagnosed. It was often accredited to being a patient with lupus. We would get consults with patients that had pancreatitis, and it was felt, and they used, early on, at least during my fellowship, they used to do an IgG4 and say, oh, well, it's autoimmune pancreatitis secondary to lupus, but you wonder now as well. So we're going to talk a little bit the salivary and ocular gland involvement. So the involvement is often of the lacrimal, parotid, submandibular glands. It's symmetric in fashion. Typically, both submandibular and parotids are involved, which you don't often see in Sjögren's. So we'll see parotids often. Sometimes you don't see any gland involvement in Sjögren's, but you often will in patients with IgG4. Up to 40% of IgG4 patients will have both salivary and lacrimal gland involvement. So both salivary and gland, yeah. Anyway, typically it's painless and the glands can be swollen for years prior to the diagnosis. Eye symptoms can present with periorbital swelling like they did in this patient, and they can also have proptosis. You can actually have a mass that's actually inflammatory mass secondary to the IgG4 related disease that can allow for proptosis. It can allow for nerve damage, giving you a orbital myositis. And if you have a situation where you have an orbital myositis, certainly IgG4 related disease ought to be consideration. In my patient that had the swelling and was diagnosed with vasculitis, it was felt that the vasculitis caused this orbital myositis. But again, it makes you wonder whether that was really the case. If you look in the literature, rheumatoid arthritis is associated with the orbital myositis. Vasculitides, such as ANCA vasculitis, can be associated with an orbital myositis. But again, it kind of makes you wonder, because a lot of these cases were older than 20 years ago. Dry eyes and dry mouth are much more milder compared to Sjögren's syndrome, and they can also have a concurrent lymphoma in patients with IgG4 related disease. Lymphadenopathy is very common. It is some studies up to 80%, particularly if they got pancreatitis, an autoimmune pancreatitis, secondary to IgG4 related disease. Lymph nodes are usually rubbery, they're non-tender. They're usually up to about 2 centimeters, but can be up to 3. The autoimmune pancreatitis is something that is often seen in patients with IgG4 related disease. I believe it's about 20% of patients with autoimmune pancreatitis. 20% of IgG4 related disease patients have pancreatitis. And it's type 1 lymphoplasmacytic sclerosing pancreatitis, which there is a type 2 that's also autoimmune, but that's not related to IgG4. And often they have a mass, they can have a mass that's painless, so it can mimic pancreatic cancer. They also can have IgG4 related sclerosing cholangitis in conjunction with the autoimmune pancreatitis, but sometimes it can occur in isolation. Now, retroperitoneal fibrosis is something that rheumatologists will often see and historically have seen, and that has not been IgG4 related disease has been a consideration years ago. But it counts up to 60% of those cases, as it turns out. And it's about 20% of IgG4 related diseases in general are retroperitoneal fibrosis. Symptoms typically are non-specific low back pain, or they can present with an obstructive uropathy, just from all the fibrosis that's occurring peritoneal in the peritoneum. Acute phase reactants are usually normal or mildly elevated, just as they are with most of the IgG4 related conditions. IgG4 can affect the kidneys. It can also give you tubular interstitial nephritis. It can give you membranous nephritis. It can give you an aortitis, a periortitis. The branches of the aorta can be involved. Lungs can give you pleurisy, just like they see in Sjögren's, but it also more likely can give you interstitial lung disease, which you don't see as commonly in Sjögren's, but it does occur in Sjögren's. Thyroid is a Rydell's thyroiditis, which is usually kind of a very hard mass that can wind up obstructing surrounding tissues, so it can give you hoarseness, for instance. The lab values, generally speaking, most patients will have an IgG4 elevation, and it's usually greater than 134. I don't have the units there. Its sensitivity is pretty good. It's 97%. So it's something that I think that is of value, but we certainly can see, and there's a lot in the literature about negative IgG4. So you can't depend on that for a diagnosis. And keep in mind, it's not specific. It's seen in asthma. It's seen in pemphigus. It's seen in atopic dermatitis. And I've got another slide, actually the next couple slides, that show you all the other diseases that IgG4 can be seen in, or elevations in IgG4. So it's not diagnostic. So what other things could you see? You could see a total IgG that's elevated. You could see that subclass IgG1 that's pretty elevated. IgEs can be elevated, and you can have low C3, low C4, I believe in about 50% of the patients, 60% of the patients around there. And a mild eosinophilia sometimes can be seen as well. And these are the differentials of patients that have an elevated IgG4. You could see it in all sorts of rheumatic autoimmune diseases, rheumatoid arthritis, lupus. You could see it in spinal arthropathies and systemic sclerosis, GI disorders like hepatitis, chronic hepatitis, cirrhosis, ulcerative colitis. And you could see it in lymphoproliferative disorders. Castleman's is one of them, but you could see it in sarcoid. You could see it in lung cancer, pancreatic cancer, and urogenital cancers as well. Allergies in general, and our patient did have chronic allergies and asthma as well. And there's other ones as well that IgG4 elevations are seen in. So again, not diagnosis, but most of the patients, vast majority of patients that have IgG4 related disease will have a positive increase levels of IgG4. So what other differentials? Well, as we talked about, some of these, you can have pancreatic cancer, primary sclerosing cholangitis, retroperitoneal fibrosis. Whenever you see that, certainly you should be thinking about IgG4 related disease. Now, that could be a result of cancers, lymphoma as well, that's not connected with the IgG4 related disease. But the the majority of patients that have retroperitoneal fibrosis do have IgG4 related disease. When it comes to aortitis, parotitis, Takayasu's or Behçet's is another Behçet's is another consideration. And ANCA-vasculitis, formerly Wegener's, or now granulomatosis with polyangiitis, or is certainly a consideration. Any of the ANCA-vasculitides, sarcoid, we talked about lymphoma and Castleman's, renal manifestations. Anytime you see membranous glomerulonephritis, TIN, you should be thinking about this as a consideration, IgG4 related disease. ANCA-vasculitis, again, Sjögren's is a consideration, of course, and the Hashimoto's thyroiditis can actually look, when Rydell's is diagnosed, a lot of times preceding that, it looks like a Hashimoto's thyroiditis, they say. So anyway, so our patient's lab, he had a negative anti-nuclear antibody, and both proteinase 3 antibody and the anti-MPO antibodies, or ANCA antibodies, those were both negative. The ANA was negative. There was no evidence of lupus, and if it's positive, most lupus patients should have a positive ANA. The IgE was slightly elevated, which can be seen in patients with IgG4 related disease, and as well as the immunoglobulins, IgG, was significantly elevated at 2,900. C3 and C4 was normal in him. You can often see monoclonal gammopathies, and SPEP was within normal limits. The labs otherwise were normal. The IgG4 was elevated at 857, which is significantly higher than the 134 that is kind of the cutoff. And an ACE was done. That's not diagnostic for sarcoid, but that was negative as well. So the diagnosis for IgG4 related disease is through your clinical skills. Again, it depends on what organ's affected. Sometimes it's really hard to know what's going on. You'd want to get a lot of times a CT to see if there's a mass there that can be biopsied, for instance. And pathology, you need tissue. And the criteria is usually for a biopsy, a significant biopsy that's supportive of IgG4 related disease, is a biopsy that demonstrates a lymphoplasmacytic infiltrate and IgG4 positive plasma cells, 30 to 50 per high power field. We had more than that at 100. Typically, you want to see a storiform fibrosis, which you're not going to see so much on lymph nodes. And I've seen that sometimes it's difficult to get in salivary tissue as well. And often you can see a obliterative phlebitis where you see remnants of veins or venules in the biopsy. So those are some of the significant findings that supports the diagnosis. But really, it takes all of these three things to come up with a diagnosis, because the biopsies often aren't that complete to have all these features, and they're also, you can sometimes see IgG4 and other diseases on biopsy. So IgG4 plasma cells, for instance, can be seen in other diseases. So for treatment, it's prednisone. It's usually like a 0.5 milligram to about 0.6 per kilo to start with, and they're usually pretty responsive to the prednisone. The problem is you can't keep them on prednisone, and as you decrease the dose, find that patients that the disease comes back. So what you can do is give a steroid-sparing drug like mycophenolate mofetil. Azathioprine has been used too, although we don't know really, we don't have a lot of support that these are indeed steroids sparing. There hasn't been really great studies on that to prove it, but that's what often is done by rheumatologists. If there's multiple organs involved, or if it's life-threatening, rituximab certainly is used and is very effective. And there's many who advocate utilizing rituximab from the get-go. And that's pretty much it. There's my references. I really thank all of you for your attention and interest. And again, thank you so much for the invitation. Let me just stop sharing. Does anybody have any questions? We have about 15 minutes left.
Go ahead, Dr. Ruby.
Mike, this isn't the most earth-shattering question, I'm sure, but I'm always curious about the smaller things sometimes. And I noticed that your title is Sjögren's disease? All my life I've known it as Sjögren's syndrome. But it does seem to be much more descriptive and stable, even though it's challenging. So I don't know if that's an elevation to call it a disease, but is that the better terminology really now to use?
Yeah, it has been. It has been for a number of years now. I don't, probably within somewhere between the last 5 and 10 years. I'm not sure exactly when. And I still find myself calling it Sjögren's syndrome because I'm just so used to it. It's such a reflex to call it that. And I had to actually, when I was doing this, correct my, I'd slip up and put Sjögren's syndrome in. But yeah, you've got biopsy evidence of it, of Sjögren's. You've got, right? I mean, there's the pathophysiology that's been described for it. It is a distinct entity that isn't just merely a syndrome. So I view it as certainly an elevation, and I think that it was needed, probably long overdue, that it became a disease rather than just a syndrome.
Yeah, sure.
Any other questions? Yeah, it's interesting with the dry mouth and dry eyes. I just kind of wonder, again, how many of those, if they're severe, well, or even mild, I suppose, as I was pointing out, are actually this entity. So I think we're going to be hearing more of it, but we'll see. I think it's an interesting area. I hope you all find it the same interest.
I imagine it's still one of those kind of things that for a lot of clinicians, it doesn't rise high enough to the top when you're trying to think of things in the diagnosis. It's one of those kind of that you don't want to miss it, but if you don't see it very often, it doesn't come up, in the scale, I guess.
Right. So absolutely, and I think there's probably needs to be much more research about early symptoms, early signs, and it's very interesting because I think a lot of rheumatologists have missed it and probably continue to miss it because if you look at the treatments, prednisone, right? I mean, and they're responsive to prednisone, so you think you got a diagnosis because let's say the serology was positive for ANCA, as it was in this one patient that I had that was diagnosed with ANCA vasculitis, and it was based on serology. So the patient had had a ocular myositis, had a pseudotumor present, and they had serology done with a mildly elevated ANCA and PR3, I believe. And it wound up that the patient had no other manifestations, and they were treated with prednisone, got better, and all was good, right? They gave the diagnosis of vasculitis. So to me, it was quite interesting that, given this, was this actually a different entity? So I think that's quite something. So, all right. Well, there's not.
Thank you for your lecture. Excellent topic. Excellent talk about the topics of IgG4. I was wondering, doctor, like you practicing the rheumatology or inflammatory situation, how often you have a chance, or how often you decide to check this IgG4 level in your practice? Once in a while, occasionally?
Occasionally. It's not still that frequent. And I wouldn't expect it to be really that frequent given that it's, 1 in 100. It might increase, right, as we become more aware of it. So when do you order this? I think, like I said, if you have somebody with, let's say, in this situation, with Sjögren's, with some unusual, or presenting as a Sjögren's patient with some unusual manifestations, or manifestations you normally see that often, like the swollen eyes, like all the parotid involvement, submandibular involvement that was going on, I think it's something that should be considered. These patients, by the way, often do have a history of sinusitis and chronic allergies prior to the diagnosis. And so you got to have a little bit of a pretest probability because, like I said, the IgG4 is not specific. It's sensitive, fairly sensitive. So if it's positive, it tells you that it could be it. If it's negative, still could be it, but maybe less so, right? So you gotta, if it's positive though, it could be a lot of other things. So you gotta still have a pretest probability. And usually you're ordering it when things don't quite fit. So I've had an unusual patient that had a C3 glomerulonephritis, a lot of C3 deposition, a lot of antibody deposition occurring in the kidneys on biopsy, almost looking like a lupus type of manifestation. And also had a biopsy that looked like an ANCA-vasculitis and serology that was positive for ANCA-vasculitis. And she had a saddle nose deformity like you'd see in ANCA-vasculitis, specifically Wegener's or granulomatosis polyangiitis. But the biopsy of these antibodies that were deposited in the kidney, you don't normally see. So that was something that was a consideration. Now, biopsy didn't show any evidence of IgG4-related disease. But those are the type of things that you kind of say, gee, could it be these situations? I think the pancreatitis without any other reasons merits an IgG4. A non-specific back pain, you get an MRI and you see changes that are consistent with a possible retroperitoneal fibrosis. Those might be an indication for it. Those are the type of things, lymphadenopathy with a patient without much in the way of symptoms, no fevers, no weight loss, that could be a consideration too. But ultimately, you really need a biopsy. That's really what's going to be needed in these situations, and they're going to tell you the story much more so than in an IgG4 level in the serum.
Thank you. Thank you very much.
And IgG4, by the way, you can follow it you can follow it. It's not for most patients. Some patients you can't because sometimes they're negative or they're not that highly elevated. So, and you got to be careful about other things going on that will raise your IgG4. But you often will see it go down, that level go down as you use treatment. And his wound up to be normal with treatment. Mm-hmm. This patient that I saw had prednisone, and then I treated him with azathioprine, with always a consideration that I might be using Rituxan if it didn't do better.
Great. Thank you very much.
Well, I thank you all, and I don't know if Mariel's still on, but I think
yes,
that's about it. I really appreciate the invitation, and I really enjoyed speaking to you all.
All right. Thank you, Doctor, for your insightful presentation. So we are coming towards the end of our time here. Just a reminder, this recording will be uploaded to our YouTube channel within 1 to 2 days. And if interested, please use the link in the chat to sign up for our monthly Global Grand Rounds invitation. Our next Global Grand Rounds will be on March 13th. And as always, we appreciate your participation and continued interest in Global Grand Rounds. Have a great rest of your day, and we hope to see you again. Thank you so much.
Bye. Thank you.
Say hello to Dr. Good.